Thank you, Mr. Chairman. And Dr. Patel, in your testimony, one of the recommendations that you make is that higher payment for facility-based services that can be performed in a lower cost setting should be eliminated. Could you elaborate on that a little bit?
Yes. Thank you, Senator, for pointing out one of our recommendations on physician payment overall. In truth, right now there have been, because of the formulas assigned for calculation of facility-based payments, there is a differential such that, for example, if a physician had performed an ultrasound of the heart in an outpatient, standalone, community-based office, they would receive a certain dollar amount, approximately $159 for that. In a hospital-based facility, that for the exact same physician, the exact same service, no additional personnel, no trainees, residents, students, or fellows involved, same exact service, same patient, can receive about 3 times that amount as a payment. And that's just one example of some of the site service differential payments, which we think are an opportunity for savings in the Medicare system.
Do you think that this differential in payment that you've described is one of the driving factors behind what we are seeing now with so many hospitals purchasing physician practices?
It's one of the main driving factors, and it's an area of concern that we have as not just physicians, but in looking at the financing of the Medicare system, we think it's sending the wrong message for the care for our patients. Now, that doesn't hold to exception training institutions and places that have additional factors, but that's not the cases that we're discussing.
Thank you. And Mr. Steinwald, in your testimony, you indicate, as I think almost everyone has indicated, that policies need to be developed to encourage providers to elevate value as the chief objective in determining what services are performed. Could you just tell me what 2 or 3 of those policies you think are the most promising that we should be focusing on?
Right. I'll start by repeating what I said a moment ago, is never underestimate the power of fee-for-service incentives to generate volume. So you're dealing with that underlying incentive. And your objective, while we're still using the fee schedule and still paying fee-for-service, is to find countermeasures, if you want to call them that, to make sure that we're rewarding value instead of volume. So such things as things that have been done in the private sector, like prior authorization for payment for expensive imaging technologies, using physician profiling, which Medicare has done just to provide feedback, but perhaps put some teeth in it to make sure that that the physicians who are overusing services are not rewarded for doing that. As long as we're going to rely somewhat on fee-for-service to pay for services to Medicare beneficiaries, we're going to have to deal with the volume incentive. I also think that we ought to coordinate payment policy with coverage policy. You know, there's 2 ways of dealing with a low-value service. One is to pay less for it. Another is to not cover it if there's a more high-value service that's a substitute. So that's another thing I think that needs to be considered, coverage policy in addition to payment.
Thank you very much. And Dr. Miller, you just mentioned the fact that you think one of the concerns or causes of our inability to get there in terms of finding the right alternatives has been the lack of the organizational structure that is necessary to help us transition to a new and more successful payment system. Could you describe the organizational structure that you're talking about there a little more specifically?
Well, I mean, I think what the Commission is mostly focused on at the moment is the accountable care organizations that were created by law and also being run out of the Innovation Center, the pioneer accountable care organizations. And I think the line of thinking is that, you know, related to what Dr. Patel said, you can either sort of lay out lots of different incentives for physicians to try and follow and rationalize, and I think she's right that currently there's an array of them. They probably have some effect, but they're also relatively confusing. Or alternatively, say, you can organize as a set of providers, accept some degree of risk, and then as a group of physicians decide what clinical evidence and pathways you're going to pursue. But the key thing is to come together as a group of providers, organize, and then accept on a population basis, a risk-based payment, and then pursue and then the federal government should obviously have some kind of quality measures to be sure that care is being provided, but those can be much more aggregated and population-based. So I think that's the line of thinking, and there is at least something of a structure there that's starting to emerge. I also want to say one thing quickly on the site-neutral point that you asked Dr. Patel. We also have a recommendation on that from a year or so ago, and we have some upcoming research on some other ideas along those lines that'll come out in June if you're interested in that.
Thank you. I am very interested. I look forward to that.
Yeah, sorry to change topics there.
No trouble.